Welcome, Charlie.
Yay, Charlie.
Yeah, this is first time I'm on this side.
Okay, so now we're streaming live on YouTube and we can, are we recording?
Yes. Recording.
Might as well just start everything.
Recording started and
Yep.
the stream is up.
Okay.
Please commence.
All right, so one more minute, we'll get started. Again, we're going to do this as a joint REMAC and medical standards. So we'll do the attendance for both at the start so that we can make sure we have a quorum. And this way, as we go through the protocols, we will vote on them as we go. And we'll go over all the rules in a minute. And for those of you who are by a computer and you can turn on your camera, I would appreciate if we could make this as close to being a real meeting in person as possible. So if you could turn on your cameras, that would be appreciated. Thank you, everybody. All right, Marie, it's 5:10. If you want to at least get started.
Yes, sir.
Standards, I think we can go from there.
Okay, I'm going to start with medical standards attendance. This is the REMAC and medical standards meeting of the New York City Regional EMS Council, April 13th, 2021. Please respond when I call your name. Paul Barbara.
Present.
Jonathan Berkowitz.
Here.
Cindy Pasilios.
Here.
Joseph Bove. Neil Semilovic. Wallace Carter. Yeah, Dr. Carter said he might be a little late. Robert Croup.
Marie, you're on mute.
You mute me. Okay. So here we go again. Wallace Carter. Can anybody hear me?
We hear you.
Yeah.
Okay. Robert Croup. Jeffrey Douglin.
Kosterko and Lee are here.
Okay, great. Reed Caldwell. Okay. David Lobel. Matt Friedman.
Matt Friedman is here.
Thank you. Okay, it's Dr. Friedman. And Jeffrey Raybridge. Michael Redlener.
I'm here.
Thank you. Joseph Schenker.
I'm here.
Anthony Shalish. Rafael Torres. Jason Zimmerman.
Jason's here.
Thank you. Nick Alexandru.
Hi, Marie, I'm here.
Hi, Nick. Glennis Seda.
I'm here.
David Benelli.
Present.
Dario Gonzalez.
Here.
Doug Isaacs.
Present.
Bradley Kaufman. Anne Marie Grigenti.
Here.
Thank you. Kevin Ward. Okay, Kevin said he might be a little late. Grace Cacciola. Grace?
Here. Yep,
Thank
here.
you.
Sorry.
That's okay. Maddie Fong,
Present.
Sean Graves,
Present.
Michael Vatch, Robert Ackerman,
Here.
Morty Lax,
Here.
Art Cooper,
I'm here.
thank you. Yadidra Langsam,
Present.
thank you. Louis Marshall, Kevin Munjal,
Here.
Jessica Van Voorhees. Okay, and that is medical standards. We have quorum. And let's get rid of that. And now I'm going to do REMAC attendance. Grace Cacciola,
Here.
thank you. Sorry, I'm calling a lot of people again. Glenna Seda,
Here.
Bradley Kaufman, Dario Gonzalez,
Here.
Nathan Reisman,
Here.
Pam Lai,
Here.
Nick Alexandru,
Here.
Doug Isaacs,
Present.
Anne Marie Grigenti, Samia McEachin,
Girl. She drives her crazy.
Hey, Marie, it's Anne Marie. I'm here.
thank you.
She's getting bigger.
Samia McEachin or Allison Burke? Jeffrey Raybridge? Jeff? Okay, we'll come back. I know he's here. Reed Caldwell? Jonathan Berkowitz?
Here.
Okay, Lewis Marshall? Michael Redlener?
Present.
Thank you. Dominic Battinelli? Efren Rendon? Joseph Schenker?
Here.
Robert Ackerman?
Here.
Joseph Bove? Sean Graves?
Here.
Arthur Cooper? Robert Winchell?
Marie, I'm here.
Okay. Mark Cantor?
Here.
Thank you. Robert Krupe? Celia Quinn? And Timothy Stiles? Laura Ivicoli?
Here.
Matthew Fink? Wallace Carter? Eric Cohen? Kevin Munjal?
Here.
Cindy Basilios?
Here.
Maria Bodick? Matthew Harris?
I'm here.
Jessica Van Voorhees? Ben Zabar?
Here.
Paul Barbara?
Here.
Thank you. David Benelli?
Still here.
I know. Okay. Peter Wire, did I call you? Okay. You did your Langsam
Present.
and Tony Shalish. Okay, let me just do a quick count. 1, 2, 3, 4.
Can I make a proposal that for future online meetings, we just join the list so we only have to do this once?
Can't do it. It will be illegal.
We can't, unfortunately, Mike, but that's a good idea.
Yeah,
like-
I like that idea too, but we are not allowed to do it. Okay, we have a quorum. Thank you very much, ladies and gentlemen. We can
so
start our meetings.
Before we get going with medical standards, we're going to do things a little bit out of order tonight because we have a lot of protocols to do. And I know that if we start with protocols, we won't do anything else. So to start with, I'm going to invite Stephen Blocker to say a few words about an app that is being developed for our protocols. Steve, you have 3 minutes, unfortunately, but the floor is yours. You're muted though, so you probably have to, there you go.
Great, hi. I had a quick presentation to run through, but if that's not the case, I can cut it down slightly faster. So my name is Stephen. I'm a paramedic from New York. My team and I are a group of paramedics and engineers that have been working on 14th and 7th in a WeWork until COVID made us go virtual. What we do, if I can share my screen and just show the app for a sec, is that we make a protocol app that takes all the medications, equipment, and protocols you have, and instead of having to find information by scrolling through hundreds of pages, we instantaneously serve it up to you.
Charlie,
So
can
show
you
you
make
what I'm-
Steve a co-host for a minute so he can share his screen?
Co-host. He is a co-host and should be able to share his screen momentarily.
Okay.
So I can. So here's what we do. When you log in, you can log in as a paramedic, EMT, or any other level. You can see in the upper right-hand corner here, you can select the agency you're part of. If you work at more than one, you can swap between them. And then you can pull up any protocol you want. So for example, if I simply type in asthma, it will find the unified protocols asthma, and I can look and read through the asthma protocol. From there, I can say that my patient is 4 years old, and it'll instantaneously see if there's a pediatric protocol instead that I can pull up, which point it'll show it. I can look it up right away. But then we can start asking other questions about that as well. Let's say my patient has decompensated past the point of a combi vent as a paramedic, and I want to give epinephrine. I can simply type in epi, and it'll immediately find the dose of epinephrine that is allowed to be given as per the protocols that you all write. Not only does it show it, but you can see it shows a repeat amount for med control underneath it, a maximum, and everything. So for that 4-year-old, as you can see, it's weight-based. So let's type in a weight, let's say 32 pounds.
Steve, whatever you have on screen, it's not changing. It's just a picture of your.
It is? Oh,
Yeah.
Hold on. Then let me fix that. Try that one more time. Can everyone see the phone screen now?
Yes.
Okay, so in the upper right corner here, I can swap between my agencies and pick whichever agency I work at. From there, I can then close that and I can say, I want to see, I have an asthma patient, type it, and it'll immediately show me the asthma unified treatment protocol. I can pull it up, read it right away. After that, I can type in epi. I can type in that is for kids. So let's say 4 years old. It'll immediately find out if there's a pediatric protocol instead, or if it's just all treated under one. I can pull that up and read that one as well. Let's say I've given them a bunch of meds and I need to go to epi as a paramedic. I type in epi. It'll show me the epinephrine that I'm allowed to give in this particular protocol. And then, as you can see, it's weight-based. I can type in any weight I want, and it'll automatically calculate the exact amount of medication I can give in that scenario, followed by telling me that as per your protocol set, I can repeat it once, but only with a med control order, and so on from there. I can also do more advanced calculations as well. I can go here, and instead of epi, let's say I have someone who's bradycardic. So as I type it in, it immediately finds which protocol that's treated under, the Brady protocol, for example. And from there, I can then say that I want to give dopamine. And when I start typing it in, it immediately shows me the protocol, but the dose, but as you can see, it's weight-based. So type in any weight you want, 156 pounds. and it'll immediately turn to a dosing infusion calculator, which means that I can then select anything I want on this list. It'll automatically tell me in the bottom which saline bag I should take off my rig and which drip I should put it with to give me the closest thing to the easiest drip per second count. I can click right on that and even see the live dosing calcs on exactly how we got there. And if I want to know any other information from your protocol set, it'll pull it up, as well as if I click in the upper left button on the upper left corner on the blue button, it'll show me the original protocol that we pulled that information from. And again, I can just flip my phone sideways and see it bigger. A few other things that we can do that's really great. If we don't know the patient's age, we can just click the human on the right, type in their date of birth, and it'll automatically calculate the age for us. I can also look up hospitals and meds. So for example, let's say we carry fentanyl. I can immediately look up my fentanyl and see every protocol that it's given in pediatric, adult, and the dosing for it, as well as any other information on that, including a picture of my vial, what I can use. If there is a medication formulary that you guys want to institute, it automatically goes in there as well. I can do the same thing for equipment, anything from a CAT tourniquet, which will show me the exact type of CAT tourniquet that my agency carries, along with the manufacturer's recommendation on exactly how to use it, all the way through the cardiac monitor that I carry, and everywhere that I can paste cardiovert or or defibrillate. From there, we also have a few other tricks, including hospitals. So I live down in Battery Park, so I can look up the hospital near me, even by nickname, let's say LMH for Lower Manhattan. I can look it up and pretty much get a customized Google Maps just built for EMS version of the hospital system. Shows me the New York City capabilities as well as New York State, any notes, COVID admission procedures, where to send the EHR to, and any other information that that hospital or you guys would like on here. I can even ask questions. So for example, I can say, LMH, does it have a burn unit? And it'll immediately tell me LMH does not have one. It'll show me what LMH has, followed by the closest burn centers to me. Call can then ring the red bat phone at the hospital if they want, and get directions pushes out to whatever nav system I use on my phone.
So Stephen, just to clarify a couple things. First of all, my understanding is that this is being implemented at the state level as a New York State project. Is that correct?
So we are currently already being used throughout the entire state of New York. We have about 2,000 providers in New York City already on the app.
Right. So then I think separately what we should do is, because I think that there's a lot of information in your presentation and I think it's great, but I think this should be a separate meeting where you can present this and everybody could be invited to see it and have the time to really ask questions that need to be asked. But I think for right now, I think it's definitely, I know that I've had the beta version and I think it's a great application, but I think that for now, it's really important that we keep going with the rest of the meeting. Otherwise, we'll be asking questions about your app all night and
Sure.
probably until tomorrow. But
no problem. Well, anyway, thank you very much for the opportunity. Oh, sorry.
So we should probably, Marie, it would probably be a good idea to have a separate meeting. And everybody can be invited to really go through the app and get a full tour of it and how it works and what questions we might have.
Yeah, no, that's great. We just wanted to introduce the program here because we needed to have everyone know that it exists. And anyone that's interested, I'll work with Steve to set up a date and we'll have a separate meeting so you can ask him more questions about this program.
Great,
And
thanks.
Steve, thank
so
you.
just one last thing to just say real quick, and then I'll let you guys get going. We attend every meeting and watch what changes as it changes. If anything that you guys vote in becomes official policy, it live notifies every provider on our platform. And the real answer is the application is entirely free. We make money through some premium versions that we'll introduce later, but the core base version of the app will always stay free to everyone. And we're just really excited to be here and just be working with everyone in the state that's willing to participate. So thanks a lot for the time, and I'll be watching the meeting anyway.
Ben,
Yeah, thank you, Steve. Yeah, I just wanted to say that's one of the reasons I really like this. We send out advisories and notices, and they always go to the leadership of the agencies. With a program like this, it's going to be pushed out to individual providers. So everyone will get our notices real time. And that's it. Thank you very much. Thanks, Steve.
Great. Ben, you had a question?
Yeah, just in general, what exactly is being, I mean, it seems like a nice program, but what is being asked of the REMAC? Is the REMAC being asked to officially support this or endorse it, or that there's an official relationship where the REMAC is responsible for the accuracy, or this is just sort of informational? Because there are other apps out there, and just to be clear, is the ask that the REMAC is going to officially be, this is the REMAC application, or is this
There's no
a
ask,
third party?
There's no ask. This is what the state is using, and we just had to present it. But I think that the point is that there should be more discussion with it at a separate time with a full presentation of the whole process. Does that sound reasonable?
Yeah, I think
Yeah,
that makes more sense.
Okay. All right. Just because I know that once we get into protocols, we're not going to do anything else. I just would like to quickly go through the other subcommittees first, and then we'll bounce back to protocols. So medical standards, it will do afterwards because that's going to be the protocol part. Executive committee did not meet. So let's go to the QA report. Dr. Redlener, if you also want to introduce what Paul had put in the chat, the quality, NAMSP quality symposium at IAC, that'd be great.
Thanks, Joe. So I don't have the minutes in front of me. I can give the basic overview of what we've discussed. As many of you know, that the REMAC has been looking at the Mission Lifeline measures, and we've put together a dashboard for the Mission Lifeline measures. I'm not prepared to present it right now, but it's worth it to present it. We made some progress on it, and I'd love to share that with you as we go forward. I think there's some opportunity to focus on some of the items that are on that quality board. And I think honestly, it's real, because it shows that we've made real progress in putting data at the front of the QI process in New York City. The other item on the list for this for the QA committee was related to what Joe mentioned before about the course. On May 6th and 7th, we're going to have the New York State NAMSP in partnership with the IAC conference. We'll be putting on a 2-day, 4 hours a day course in quality improvement. It's modeled on the national quality and safety course for the NAMSP. It would be great to have representatives from New York City join. And I think it's, it goes through a lot of the process and a lot of the methodology about quality improvement and how it's applied to EMS. So if anybody has any questions, I'd be happy to answer.
Great. Thanks a lot, Mike.
Thanks.
Okay. Training and education, Morty. You're muted.
Training and Ed did not meet. Training and Ed will be meeting on the 23rd at 12:30. We'll have information for REMSCO and I guess the next REMAC.
Okay. And I know that the RTAC meeting is, I believe, next week, right, Doug?
Yes, Joe.
Thank you so much. Okay.
And Joe.
Yes, sir.
And just, all the questions that have come up that we're going to put in our GOP will be presented at RTAC. So
Perfect.
Next REMAC, I'll present that to everyone.
No problem. Thank you very much. Okay. We're going to move towards the medical standards portion of this, and I'm going to let Dr. Benelli have the helm. But two things. First of all, I think we should do the CNC report before we get into protocol. And then finally, just before we give this, before we start moving into that, with regards to the protocols, there are an incredible amount of material that needs to get through tonight. I hope that people have reviewed it. I hope that people have looked at it in advance. I know it's been sent out. Please, 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 if the discussion starts to get out of hand, we will have to send it back to protocol and ask that whoever is discussing it attend that meeting to continue the discussion. Otherwise, we will not get through the 15 protocols that we have to get through tonight. So I ask you all to be poignant with your discussions, have read the material, and if not, it's just going to lead to a delay because we're going to have to move it back to protocol and discuss it again at our next meeting, which is on May 4th. So with that said, Dave, take it away.
Oh, thank you. Okay, good evening, everyone. So we're going to kind of do things in a reverse order. We're going to leave the protocol committee report for last. We're going to motion to approve the minutes from the last meeting. They're the mutual minutes of both the REMAC and the medical standards meeting, unless anyone has any objections. I'm sure you all read them. Marie sent them out. Please, if anyone has any objections, please let me know. Please let me know. If not, we'll accept it as approved.
Motion approved.
Okay. Okay. Having heard none, motion. We'll take this as the motion is approved. We'll move on to subcommittee reports. So CNC will be first. Then I'm going to ask the interfacility tag protocol, Dr. Berkowitz, to just give a quick report. There was a very good meeting last week, and then we will start to get into the protocols. So please brief reports, and we'll move on. So go ahead, Paul.
CNC didn't meet. There's a lot of bandwidth going to protocol for the CNC folks. There's a lot of crossover. Next meeting is May 11th. Highly urge everyone to attend. Side note, though, is the medical control credentialing is going through the new form. People are already signing up. Just for those of you out there, new people, the intake form, the class, the intake form, the written exam, and a practical of some sort. Research, the intake form, and the written exam. All right, any questions, come to me. Done.
Thank you. And Paul has put in the chat, the first item on the chat is the link to the course that we just discussed. So please attend. I think it's going to be a very good course. Next, Dr. Berkowitz, the interfacility tag.
Sure. So as you said, we had a productive meeting last week. Just to be brief, we did an outline of what hopefully will be our first pass at this. We had essentially 6 subsections: levels of care, education and credentialing, clinical protocols and procedures, medical direction, quality, and clinical operations. And then we assigned folks to the different areas. And I think the next step is going to be for people to work on those areas. We do have people taking lead on different elements within it. You know, in the end, I'm not going to go through the whole outline because it's a couple pages and probably, you know, would need a lot of explanation. But what I can do is, if folks want, I think I can share it in the chat and people can look at it. And if people want to get involved with certain subsections, that would be great, because I think that we need our collaborative brainpower to do this. So I'll throw it in the chat unless anyone has any issues, and then we can move on with the slog ahead.
Very good. Thank you very much, John. Any questions for Dr. Berkowitz before we move on? Okay, very good. So now we're going to move to the protocol committee, to Dr. Lai's report. As we said, we have about 15 protocols, if not more, to go through. The timeline is so that we must go through them today, because we have to send them up to the state, and they have to be approved by New York State in their by CMAC in their meeting on May 24th and 25th, I believe, right, Nick? And so it must go up there so we can get it approved then, and then we can publish it and start the training for the implementation date of January 2022. So the discussion is going to be, we're going to allow a short discussion for each protocol. If there is too much discussion and too many objections, I'm going to ask that you please email the protocol committee your concerns. We're going to send it back to the protocol committee, where the emails will be reviewed. And obviously, if you can attend in person, even better. And we'll review those concerns and bring it back to the next medical standards meeting, which will be on May 4th, I believe. Yes, Dr. Zabar, you have a question.
If someone just wants to make a simple change, I mean, they can just make a motion, and then the motion gets voted on, and either it passes or it doesn't, and the protocol moves on, right? So, I mean, I think there's a lot of things we can get through, even, you know, it doesn't have to get sent back if people just make the motion.
Ben, it's a matter of time. If we see that it's a simple change, we can definitely entertain that. If it becomes a long discussion, I'm not going to entertain 20 minutes discussions. We just don't have the time for it.
So the answer the answer to your question is, Ben, we're still going to follow Robert's rules. That's what we do, and that's how it works. And it is a committee structure. The discussion is what David is talking about. We are going to limit the discussion to a reasonable amount of time. If we start going back and forth on little minutia, that will get put back, it will get tabled at the discretion of the chair to the protocol committee for review there. We're not going to have prolonged discussion here because we will not get through it all, and that is not possible. That's not helpful. Does that make sense? Thank you.
Okay, very good. Having set the ground, Dr. Lighty, stage is yours.
Perfect. Thank you, David Benelli. So I'm going to start sharing my screen. So the protocol committee, since the last REMAC meeting, has met 4 times to be able to produce the volume of protocols that we are about to sludge through right now. So I am mostly going to go in sort of like that chronological order that Marie has kind of put in the email. Hopefully starting off with some of the minor changes first. So I'm going to first share my screen. So you should see my screen here. So this is the anaphylaxis severe allergic reaction protocol. This is a protocol that was previously passed from REMAC. What had come to light and what was discussed just at the latest protocol committee meeting was that there was a change in the national curriculum in terms of both for EMTs and paramedics, where now EMTs are allowed to administer anticholinergic medications by nebulizer. So that is including ipratropium bromide or Atrovent. So it was proposed that that we would allow that at our EMT level. So what you see now is that highlighted in red is that now the administration for ipratropium bromide mixed with albuterol sulfate has been moved from the paramedic section to the EMT section. It is still the same maximum of 3 doses. That will still be the same in terms of that for the paramedic section. You will see that if they do feel that is still clinically warranted, they are to just administer additional albuterol sulfate up to a maximum of 3 doses. As well. So the major change to this protocol was that ipratropium bromide has now been moved to the EMT section to reflect the change in the national standards curriculum.
Very good, thank you. Marie, we're going to vote for both, just like we've been doing in the previous meetings, previous virtual meetings. So again, everyone, all these protocols that Dr. Lai is bringing forward, the second in motion from the protocol committee, have been vetted, have been discussed in great detailed research, and are brought here after very long discussions over 4 meetings in order to make sure that we're bringing the right thing forward. So any discussion from medical standards from the point of this protocol? Actually, also people on REMAC, if anyone has any discussion regarding this protocol. Okay, hearing not.
We're good to go, so let's move on.
So for the Medical Standards Committee, is there anyone on the Medical Standards Committee who objects or has any concern, who objects or abstains to vote in favor of this protocol? Okay, hearing no objections, this is approved by Medical Standards. And Marie, now let's do a roll call for REMAC.
Okay. Sorry. Okay, so please respond in favor, opposed, or abstain. These votes are limited to physicians. Glennis Seda. Glennis Seda?
Yes.
Thank you.
Sorry, yes.
That's okay. Bradley Kaufman.
In favor.
Oh, you're here. Okay, great.
Oh, sorry. Here.
That's okay. Dario Gonzalez.
In favor.
Nathan Reisman.
Favor.
Pam Lai.
In favor.
Nick Alexandru.
In favor.
Doug Isaacs.
In favor.
Jeffrey Raybridge. Jeffrey Raybridge. Jonathan Berkowitz.
Yes.
Lewis Marshall. Michael Redlener.
Approve.
Joseph Schenker.
In
You want me
favor.
to hold? Okay,
You can hold it, but in favor.
okay. Joseph Bove. Arthur Cooper.
In favor.
Robert Winchell. Mark Cantor.
In favor.
Thank you. Robert Croupi.
In favor.
Okay. Celia Quinn. Tim Stiles. Laura Ivacoli.
In favor.
Thank you. Wallace Carter. Kevin Munjal.
Yes.
Cindy Basilios.
In favor.
Maria Bodick. Matthew Harris.
Approve.
Jessica Van Voorhees. Ben Zabar.
Yes.
Ben Zabar. I'm sorry, was that Jessica?
Yeah, that was me.
Thank you. Ben Zabar.
In favor.
Paul Barbara.
In favor.
David Benelli.
In favor.
And Peter Wire. Okay. So it's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21. That's 21 votes in favor, none opposed, no abstentions. It passes.
Thank you very much. Okay, Dr. Lang, next protocol, please.
Great. Next protocol is another protocol that was previously approved by this committee. This was actually like our very first protocol that was approved through this REMAC season. There was just a slight change just in the ketamine dosing after speaking to our toxicology friends over at the New York City Poison Control Center, just for a little bit of their expertise just with the dosing of ketamine. And so forth. It was just made so that it is now going to be consistent in terms of like some of its use in other protocols where now IM and IN dosing is sort of treated the same. This is this was just initially changed just through speaking with them as arranged from the protocol committee members, just for a discussion with that, so that this is consistent with other sort of like ACEP, as well as like other national guidelines that have been put forth for ketamine dosing. So the change is just that IM and IN, as you will see, is now treated similarly. So it's ketamine 0.4 milligrams per kilogram, IM, IN.
Very good. Thank you, Dr. Lai. Any discussion from medical standards or REMAC members?
Sorry, Pam, could you just clarify what was there before?
Previously, before it was the, I believe it was the intranasal was treated similarly to the IV dosing, and that now that has changed now to be similar dosing with IM.
So instead of 0.2, it's 0.4. Is that correct? For
Yes.
IM. Okay.
Yes.
Yes. This is for the general pain management protocol.
General pain management protocol. That is correct.
Okay. Any further discussion? Okay. For medical standards committee members, anyone who objects or abstains from moving this forward to REMAC? Yes, Pesach, go ahead.
Yeah, I just wanted to point out that in our excited delirium protocol, the IM dose of ketamine is double the intranasal dose of ketamine. So this would be a difference here from other places where we give ketamine intranasal and intramuscular by making it the same here and different there.
Yes, Pesach. So the difference is just because of the common concentration that is used in EMS, just for the amount that can be given intranasally. That's why there is like the actual limit on the intranasal dosing for ketamine in that specific protocol.
Okay, thank you.
Okay, any further discussion? Anyone from medical standards that objects or abstains from moving this protocol forward to REMAC for voting? Hearing none, go ahead, Mary, please.
Okay. Glennis Seda,
Yes.
Brad Kaufman,
Yes.
Dario Gonzalez,
Yes.
Nathan Reisman.
Yeah.
Sorry, I'm reverting. Pam Lai,
Yes.
Nick Alexandru.
No.
Okay. Doug Isaacs,
Yes, in favor.
Jeffrey Raybridge.
Jeff just told me he's not here.
He is not there, right?
Some
sorry.
charlatan said they were him earlier.
Okay.
Jeff, just
Bad
call him
people.
anymore.
Okay. Jonathan Berkowitz.
Yes.
Okay. Michael Redlener.
Abstain.
Okay. And Dr. Marshall's still not here, right? So I'll make sure. Okay. Joseph Schenker.
In favor.
Okay. Art Cooper.
I'm going to abstain.
Okay. Mark Cantor.
In favor.
Robert Krupe.
Approve.
And Celia Quinn and Tim are not here. Laura Ivacoli.
In favor.
Wallace Carter. Kevin Munjal.
Yes.
Cindy Basilios.
In favor.
Thank you. Matthew Harris.
Favor.
Okay, great. Jessica Van Voorhees.
In favor.
Thank you. Ben Zabar.
In favor.
Paul Barbara.
In favor.
David Benelli.
Yes.
Okay, so I'm going to do a quick count. 1, 2, 3, 4, 6, 7, 8. Okay, so that is 19 in favor with 2 abstentions.
Very good. Thank you very much. Dr. Lai, let's continue.
All right, perfect. So now you will see the updated excited delirium protocol. This was sent back to the protocol committee from the last REMAC meeting that we had about a month ago. The biggest issue and the biggest source of discussion during the REMAC meeting was the need and necessity to have weight-based dosing as well as pediatric dosing for this protocol. So you'll see that this is for adult and pediatric patients. Under standing orders, it is only for adult patients where they are able to administer midazolam 0.2 milligrams per kilogram IM/IN to a maximum of 10, or the dose 0.2 milligrams per kilogram IV with a maximum of 5, where the preferred route is IM. This is similar to our current protocols in terms of the dosing as well, in terms of the maximum dosing allowed under standing orders. You'll then see that under medical control options, we have weight-based dosing that will be given for both adult patients as well as for pediatric patients, so that you can see the updates in terms of the medications that are allowed under medical control options.
Okay, very good. So this is a protocol that was sent back to the protocol committee for further clarification regarding the pediatric dosing, which has now been corrected. Any discussion, both from medical standards and from REMAC? Okay, very good. Thank you. Anyone on medical? Yes, go ahead. Go ahead, Art.
Yeah. The EMSC committee, the State Department of Health EMSC committee, had a lengthy discussion about this today at its meeting. The committee is going to be meeting again in July. I think the general sense of the committee was that was that it was not a great idea to be considering, sedation for excited delirium in pediatric patients without a fuller review at their level. So I'm going to have to vote against this. I would hope that we would defer to the decision of the EMSD committee at the state level. And that's all I have to say at this time. Thank you.
Thank you, Dr. Cooper. Again, the pediatric dosing is only a suggestion in the medical control options. This is not standing orders. Any further discussion? Okay, hearing not. Anyone on the Medical Standards Committee opposes or objects to move this forward for voting at REMAC? Okay.
I'm against. This is Dario. I'm against.
I'm sorry. I'm talking about medical standards now.
I know.
So anyone?
Okay.
Okay. So other than Dario, is there anyone else who objects to move this forward? Very good. So with only one objection, we're going to move this now for voting at REMAC.
Dave, Art, Dario and Art.
Okay. Art, are you on medical standards as well, or just on REMAC? I'm sorry.
As far as I know, I'm on medical standards.
Okay, so two objections. Very good. I'm sorry, Art. I just wanted to make sure. Okay, anyone other than Art and Dario that object? Hearing none, let's move it forward to REMAC for voting. Marie, please.
Okay. Glennis Seda.
Yes.
Bradley Kaufman.
Yes.
Dario Gonzalez.
No.
Nathan Reisman.
Yes.
Pamela Lai.
Yes.
Nicholas Alexandru.
Yes.
Doug Isaacs.
In favor.
Oh, Jonathan Berkowitz.
Yes.
Michael Redlener.
I'm going to abstain.
You could abstain? Okay. Joseph Schenker.
In favor.
Okay. Arthur Cooper.
No.
Mark Cantor.
In favor.
Robert Krupe.
In favor.
Laura Ivacoli.
In favor.
Wallace Carter. Kevin Munjal.
In favor.
Cindy Basilios.
In favor.
Matthew Harris.
Abstain.
Come on. And Jessica Van Voorhees.
In favor.
Benjamin Zabar.
In favor.
Paul Barbara.
In favor.
David Benelli.
In favor.
One, two. Okay, we have 2 opposed and 2 abstained. So that's 18 in favor. It carries.
Very good. Thank you, Dr. Lai. 6 p.m. We're at the 4th protocol.
Okay. Just to let you know, we have our quorum is 16, so anything over 16 carries.
Thank you.
Sorry, take myself off mute. So next we have the respiratory distress, respiratory failure protocols for adult. There was not much change from the current protocols that was here, except for just some clarification for language for this protocol. It is stressed in this protocol for CFR and all provider levels that providers should be using airway adjuncts appropriately as needed and administer oxygen as listed. The other big change for this protocol, you will see that this is for in terms of for the patients with suspected acute cardiogenic pulmonary edema and whose patients who have the systolic blood pressure of greater than 120 millimeters of mercury, that paramedics are able to administer nitroglycerin, both sublingual and IV, every 5 minutes as needed. The IV is the new dosing that has been added to this protocol. There has been recent studies, well, actually quite a few studies that do show the benefits of administering nitroglycerin via the IV route if available for pre-hospital providers. Otherwise,
Good.
you'll
And
see
this
that
is
for the medical.
Go ahead. Sorry.
I'm sorry. And then you'll see just for the medical control options, furosemide is still there. The other medications, the benzodiazepines for the anxiolytics for CPAP usage, has been moved to a later protocol that we will discuss later tonight, hopefully.
And to make it very simple and very easy, the IV dosing is not via drip; it's just boluses, small boluses. Okay.
That is correct.
Any discussion regarding this protocol?
Yeah, David, it's Nick. I just have a question. I think I heard Pam say that the IV nitro, if available, but I don't see it there if available, unless I'm missing it. It says as needed. Does that need to be included? I'm sorry.
So it is that nitroglycerin can be administered via the sublingual or the IV route. We can put in language in there to make it more clear if we wanted to have it as a if available on there. I guess if I guess motion by REMAC. So.
I mean, there's no. I mean, we have the sublingual option, and if it's not available, if the agency doesn't carry it, then they still have the sublingual, right?
Can I answer as the? Can I answer as the? Creator
yes.
or whatever.
Yes,
Nick,
and then Pesach is next.
Nick, the intent was never to mandate anyone carry anything, but more to expand the scope for services that wanted to carry IV. It's not meant for people to carry both. It's meant, if you carry sublingual, you carry sublingual. If you want to give IV, you can give IV. The point is we don't want to break the mask seal on the CPAP and have a different route to give the nitroglycerin rather than pulling the mask and going near the airway, more aerosolizing procedures, if the service decides that IV nitro is appropriate.
No, that's fine. The only thing is usually we write if available, and our protocols not as needed. So it's not quite clear that you could use it one way. It says that you could use it one way or the other, but it doesn't allow you to have it as a separate option if available.
Okay, understood.
Yeah, I agree with you. I agree with your point, Nick. But how do we have it for other? Do we write or? What's our vernacular for that?
No, we just write if available, right? I mean, have IV nitro.
I'm not against writing if available, but we should be carrying nitroglycerin.
But I think in other protocols, when we say this or this or this, like with the benzos, it's assumed that as long as you have one of those options, it's only when there's a protocol that says step 12, do X, that if you would write if available, because some people might not have X. But if they have one of the options, I don't think we usually say if available, if any of the options are acceptable.
That is correct. For instance, if FDNY doesn't carry Ativan and we don't, there's still not an if available for Ativan. Pesach, you're raising your hand. I'm sorry.
Yeah, I was going to basically say what Ben is saying, that we only write if available when the entire step is optional. But if you have a way of completing that step through any of the available options in that step, then you've met your requirements as an agency of being compliant with completing the protocols, and we don't need to write if available if we only want to make one of the ways of completing that step optional.
Thank you very much. Any further discussion? Very good. Hearing none.
I have a question. I have a comment.
Yes, yeah. Go ahead.
Okay. I understand what Pesach just said, and it is true, but it is confusing. That type of deduction, okay, is not clear to many agencies, and many agencies will read it as understanding they must have it or not have it. And I would urge you to make it a little clearer. It wouldn't hurt to put the words if available on particular that you're not expecting everyone to carry. Otherwise, I think it's just confusing. That's just my 2 cents.
I'm not sure that I follow because, I mean, we don't have it already. The FDNY doesn't carry Ativan, but it's still in the sedation protocol. Do we have it available next to Ativan?
Yeah,
I mean, do we have available next to in the seizure protocol for Ativan?
As needed is there because of the blood pressure component.
But
Meaning that
And that's just because they're able to administer every 5 minutes as needed. And that's why that as needed is there.
The only thing is that the benzos are usually listed separately, not together when they're given in different forms. So,
Well, I wouldn't expect us to do sublingual and IV, right?
Well, I guess that comes down to the other issue. Maybe we should resurrect a formulary, put it into an appendix, and list if available on those items, not only drugs, but also equipment that are if available items, which would then be clearer. But I think we are giving mixed messages to people. If you don't think so, it's fine. But down the line, someone's going to complain one way.
Okay. Okay. Is there a motion on the table to make any changes at the moment? Or maybe we can entertain later to put to create a formula, an appendix, or whatever means to whatever tool that we find appropriate.
I would make a motion that we later, when we have a moment and we're not against the wall, that we make a formulary and put it into an appendix.
Second.
Okay, very good. Do we need to vote on this? Does there anyone? Go ahead.
The motion
I'm
that
sorry?
Yadidya is making is an inappropriate motion because the motion on the table is the seconded motion of the protocol. So we have to vote on that protocol first. And then if Yadidya wants to make a motion for a formulary, that would be made after we completed the vote of the current motion, because the motion Yadidya made has zero relevance to the protocol that's on the table right now.
Don't be so smart, because I can make the motion. I can make the motion as an amendment to the protocol, the motion currently on the table, okay, to make an amendment that we add the creation of a formulary to the approval of this motion. Now, having said that, not to be too smart, I will be willing, if you make a note of my motion,
But then we'd have to vote 3 times, Yadidya. That's the only difference.
Okay, just
We don't need a motion to make a formulary, guys. Let's stop wasting time, please.
Put it for later. That's all. Make a note that I've asked to do this, and I'll reintroduce the motion later. But you know,
exactly.
I can Robert's rules you with my eyes and closed. Just remember.
Okay, guys. So Yadidya, Dr. Lai, why don't we make a note for the protocol committee to create a formulary, an appendix with formulary as to what medications are mandatory and what medications are if available. And let's move on with the any further discussion regarding this protocol. Having heard none, is there anyone in the medical standards committee who abstains or objects to moving this protocol as for vote in REMAC?
I abstain.
Very good. Anyone else? Okay, Marie, let's proceed with the vote on REMAC.
Okay. Glenn Seda?
Yes.
Bradley Kaufman?
Yes.
Dario Gonzalez?
Yes.
Nathan Reisman?
Yes.
Pamela Lai?
Yes.
Nicholas Alexandru?
Yes.
Doug Isaacs?
In favor.
Jonathan Berkowitz?
Support.
Michael Redlener?
In favor.
Joseph Schenker?
In favor of the motion for the protocol, I would like to table Yadidya's motion to the future.
Arthur Cooper?
In favor.
Thank you. Mark Cantor?
In favor.
Robert Crupi?
In favor.
Laura Ivacoli?
In favor.
Kevin Munjal?
Yes.
Cindy Basilios?
In favor.
Matthew Harris?
In favor.
Jessica Van Voorhees,
In favor.
Benjamin Zabar,
In favor.
Paul Barbara,
Abstain.
David Benelli.
Support.
Okay, so we have 20 in favor, 1 abstain, no votes against, it carries.
Thank you. Yadida, is that hand an old one or a new one?
That's an old hand.
I know we're looking at it. Marie, Tim Stiles is on the call as well.
Oh, okay. Dr. Stiles, how do you vote?
In favor.
Thank you.
Okay, let's move on to next protocol, Dr. Lang.
Okay. 1 second. All right, so the next is the respiratory distress, respiratory failure protocol for pediatric patients. This is very similar to the adult protocol that was just reviewed just now. A lot of this is very similar language to what was in this protocol from before, without any major changes on here.
Okay, any
David?
discussion? Okay, no discussion. So anyone on the Medical Standards Committee opposes or abstains moving this forward to REMAC for vote? Very good. Go ahead. Yes, go ahead, Pesach.
Just in the bottom and the key points and considerations, the definitions for characterizing respiratory distress versus respiratory failure seem to have a lot of crossover and redundant, and not redundancy, but things that point to both definitions at the same time. And I was hoping
Sure.
that could be cleaned up.
I'm
Right,
sorry,
so
I
Pesach,
thought
so,
that
I
this
mean,
was,
as you know,
this was discussed.
I'm sorry, David.
This was discussed ad nauseum in the protocol committee.
So this was, yeah, so
Go ahead,
David,
Mary.
so just to very quickly just to address that. So, I mean, as you know, Pesach, there are a lot of overlap between a lot of the signs and symptoms between respiratory distress and respiratory failure with sort of the, and Matt Harris can chime in on this if he feels that it's warranted, but a lot of it is going to be that distinction with patients having central cyanosis and having the presence of hypoxia or hypercapnia versus the respiratory distress of having a lot of those similar symptoms without the central cyanosis.
Pam, I think you said that well. I mean, I think there is a lot of clinical crossover. It's a spectrum, right? So we have to treat it as such.
Very good. Any further discussion? Anyone on medical standards opposes or abstains moving this protocol forward to REMAC for vote? Okay, hearing none, Marie, please do a roll call for REMAC.
Glenna Seda,
Yes.
Brad Kaufman,
Yes.
Dario Gonzalez,
Yes.
Nathan Reisman,
Yes.
Pamela Lai,
Yes.
Nick Alexandru,
Yes.
Doug Isaacs,
Favor.
Jonathan Berkowitz,
Yes.
Michael Redlener,
Yes.
Joseph Schenker,
In favor.
Arthur Cooper,
Yes.
Mark Cantor,
In favor.
Robert Crupi,
Yes.
Timothy Stiles,
Yes.
Laura Avicoli,
Yes.
Kevin Munjal,
Yes.
Cindy Basilios,
In favor.
Matthew Harris,
In favor.
Jessica Van Voorhees,
In favor.
Ben Zabar,
In favor.
Paul Barbara,
In favor.
David Benelli.
Affirmative.
It's unanimous.
Very good. Next protocol, Dr. Lai.
Great, just 1 second here. So the next protocol that we have is going to be a combined protocol for asthma, COPD, and wheezing, both for the adult and pediatric patient. For this protocol, the CFR section has not changed. However, this now has the previously approved ipratropium bromide at the EMT level, so that you'll see that for adult patients and for pediatric patients whose age is greater than or equal to 2 years old or greater than or equal to 18 months with a history of albuterol use, they're able to administer ipratropium bromide with albuterol sulfate to a maximum of 3 doses. That will be dependent on, with the dosing will be dependent on age for the pediatric patients. It is the same that that providers are to initiate transport after starting the administration, but that they are not to delay transport to complete the medication administration. Again, epinephrine is still here, similar dosing, similar formatting to previous protocol and the anaphylaxis protocol for the EMT level. For the paramedic section, we do have the continuation of the albuterol sulfate here. For the paramedic patients, so that they do not go over the recommended 3 maximum doses for the ipratropium bromide. Afterwards, we do have the dosing for the steroids for patients with persistent symptoms with dexamethasone as well as methylprednisolone. That will be weight-based dosing. And then also as well for additional epinephrine dosing as needed for patients who are in severe respiratory distress, respiratory failure, and or shock. That there's the epinephrine dosing for the paramedics on there. Additional medical control options for the EMT level is going to be additional epinephrine as well as additional albuterol sulfate doses. For the paramedic level, it'll be additional epinephrine as well as additional albuterol, as well as for pediatric patients, the administration of magnesium sulfate, weight-based dosing, and then also for the pediatric patients who do not fit the standing order age criteria, so those patients less than 2 years old, to contact medical control for the administration of the steroids, as above.
Very good. Anyone has any discussions regarding this protocol? Anyone from medical standards or from REMAC? Okay, hearing none. Anyone on medical standards opposes or abstains from moving this protocol for approval by REMAC? Okay, go ahead, Marie.
Okay, Glennis Seda,
Yes.
Bradley Kaufman,
Yes.
Dario Gonzalez,
Yes.
Nathan Reisman,
Yes.
Pamela Lai,
Yes.
Nick Alexandru,
Yes.
Doug Isaacs.
Favor.
I'm sorry, Doug, you said yes or no?
Yeah, yes.
Okay, sorry. Jonathan Berkowitz,
Yes.
Michael Redlener,
Yes.
Joseph Schenker,
Yes, in favor.
Arthur Cooper,
Yes.
Mark Cantor,
Yes.
Robert Krupe,
Yes.
Timothy Stiles,
Yes.
Laura Ivacoli,
Yes.
Wallace Carter. I think Dr. Carter just got in.
Yes, I did. Marie. Sorry about that. Traffic was awful.
That's okay. We all have to work. That's life. Okay, hold on 1 second. Kevin Munjal,
Yes.
Cindy Basilios,
Yes.
Matthew Harris,
Yep.
Jessica Van Voorhees,
Yes.
Benjamin Zabar,
Yes.
Paul Barbara,
In favor.
and David Benelli.
In favor.
Unanimous.
Thank you. Dr. Lai, the next protocol, please.
Great. So moving forward, we have the Stridor, Croup, and Epiglottitis protocol for pediatric patients. The I think from the current unified protocols, the changes are sort of the addition of both L-epinephrine as well as racemic epinephrine to be given as either options to be given for children with stridor at rest. In addition, that there is also additional orders for patients who are greater than the age of 2 years old with stridor at rest, respiratory distress, or persistent barky cough. They are to administer weight-based dosing of the steroids that is similar dosing, as well as similar maximum dosing that has been seen throughout all of our protocols. And under medical control options, it is the administration for the steroids for those patients aged less than 2 years old with the same symptoms that was listed in the standing orders.
Very good. Thank you, Dr. Lai. Any discussion regarding this protocol?
One quick question, David. It's Jason.
Sure.
The standing orders for the 3 milligrams for the paramedics for all ages for pediatrics?
Yeah, hey, so this is a topic of frequent conversation that came up multiple times at the protocol committee. In most pediatric ERs and ICUs, it is a standardized dose. They don't split the dose in half. I recognize it differs from the state is behind the times.
Yeah, right.
Thank you, Dr. Harris.
Discuss the 1 milligram versus the 3 milligrams versus the 5, and the younger, the middle, the toddler, that whatever. But okay.
I spoke with a
did
couple
3.
of our pharmacists at Children's, and again, you guys can reach out to your own institutions if you want, but this seems to be pretty standard practice.
Very good. Pesach, you have your hand raised.
Yes, please. I would like, if possible, unless Matt thinks it's inappropriate, to remove the dilution of the standard L-epinephrine in an additional 3 ml of saline. I don't think it's necessary, and the state allows it. The state protocol has it as just 3 milligrams straight without any dilution. It would make it simpler for our paramedics if we could remove that step.
Dr. Harris?
I don't see why that would be an issue. It's the same. It's the same dose. It's just the dilution. It's a little bit different, but I don't think that's unsafe.
Okay, so Pesach, are you raising a motion to correct this dosing?
Yes, I'd like to make a motion so that step 9, option A would be the same without the last part of the sentence saying to mix it with saline.
Okay, very good. Any discussion?
Need a second.
Okay, is there a second? Oh, who was second?
Matt, second.
Okay, cool. Any discussion?
This is Brad. You can't take out the part that says via nebulizer because that's important.
Of course.
Thanks, Brad.
You can always count on you, Brad.
Thank you.
Okay, cool. So now we're going to vote on the amendment and then on the protocol at the medical standard level. So anyone objects or abstains for the amendment as approved as proposed by Pesach and second by Matt? Excellent. So the amendment is approved. I see Pam already corrected it on the protocol. Anyone on medical standards objects or opposes or abstains from moving this for vote at REMAC?
I'm sorry. So are we making the same change to option B in step 9?
Okay. Good question.
So Brad, I believe that it's only for the L-epinephrine.
Okay.
Because even for the state, the 0.5 mLs for the racemic epinephrine is mixed with 3 mLs of normal saline.
Yeah, I was only referring to L-epi.
Excellent. Okay. Any further discussion before we vote or before we move it forward? Anyone objects or opposes or abstains from moving this for REMAC for voting for approval? Thank you. Marie, please do the roll call.
Yes, sir. Here we go. Glenna Seda.
Yes.
Bradley Kaufman.
Yes.
Dario Gonzalez.
Yes.
Nathan Reisman.
Yes.
Pamela Lai.
Yes.
Nick Alexandru,
Yes.
Doug Isaacs,
Yes.
Reed Caldwell, Jonathan Berkowitz,
Yes.
Michael Redlener,
Yes.
Joseph Schenker,
Yes.
Arthur Cooper,
Yes.
Mark Cantor,
Yes.
Robert Croupi,
Yes.
Timothy Stiles,
Yes.
Laura Ivacoli,
Yes.
Wallace Carter,
Yes.
Kevin Munjal,
Yes.
Cindy Basilios,
Yes.
Matthew Harris, Jessica Van Voorhees,
Yes.
Ben Zabar,
Yes.
Paul Barbara,
Yes.
David Benelli.
Yes.
Unanimous.
Thank you. Next protocol, Dr. Lai, please.
Great. Next protocol I have is for a updated change to the non-traumatic cardiac arrest patients for adults. It was reviewed when we were doing the adult dysrhythmia protocols, that the discussion was brought up with the addition of lidocaine. That has now been with the new AHA guidelines that have been released in October of this past year. So it was decided by the protocol committee to include this as an option for an antiarrhythmic medication, so that now for the section over here, for the administration of either amiodarone or lidocaine, that will be given as both as one of the medical control options as well as understanding orders to be written as options as seen.
Okay, any discussion? Hearing none. Is there anyone on the Medical Standards Committee who wishes to object, to abstain from moving this forward to REMAC for vote? Okay, very good, Marie. Do the roll call, please.
Glenn Esteda,
Yes.
Bradley Kaufman,
Yes.
Dario Gonzalez,
Yes.
Nathan Reisman,
Yes.
Pamela Lai,
Yes.
Nick Alexandru,
Yes.
Doug Isaacs,
Yes.
Jonathan Berkowitz,
Yes.
Michael Redlener,
Yes.
Joseph Schenker,
Yes.
Arthur Cooper,
Yes.
Mark Cantor,
Yes.
Robert Croupi,
Yes.
Timothy Stiles,
Yes.
Laura Ivacoli,
Yes.
Wallace Carter,
Yes.
Kevin Munjal,
Yes.
Cindy Basilios,
Yes.
Matthew Harris,
Yes.
Jessica Van Voorhees,
Yes.
Ben Zabar,
Yes.
Paul Barbara,
Yes.
David Benelli.
Yes.
Unanimous.
Thank you, Dr. Lai. The next protocol, please.
Great. So the next protocol, I'm sorry, I mislabeled that in Marie's original email. This is a new protocol that's being brought forward from the protocol committee for the sister protocol for the non-traumatic cardiac arrest for pediatric patients. So again, there was not much that was really changed in terms of the current language from this protocol compared to our current protocols, I'm sorry. But I think that there is just a little bit more clearer language, I think, that was used for this protocol. So you'll see there's a lot of similar language that is used both in the CFR as well as the EMT sections that's reflected in the adult protocols. And then now there's just the clear language in terms of the defibrillation with the initial, second, and subsequent defibrillations that's needed. Lidocaine is also present in this protocol as well. Otherwise, everything else I believe is the same, including the medical control options that were not changed from the current protocol.
Thank you, Dr. Lai. Any discussion? Both for medical standards and REMAC members. Hearing none. Anyone on the medical standards committee opposes or abstains from? Yes, Pesach.
Just in the paramedic section, we're talking about AED pads when we're
I know it's minor, but we're using manual pads. I don't know if we want to change that.
Can you repeat the comment?
Just the word AED in step 9.1 as paramedics using a monitor. If we're using the monitor, then we're not using necessarily AED pads. We can make it simply pads.
I'm sorry, we use paddles?
No, so PASOC is just saying that just to remove the word AEDs, that it should just be used as, the language should just be pads on there, since these are just being monitored, not from the AED. So the removal of the word AED on there.
I think this is
that makes sense.
graphical, and I think that the intent is for it to be pads. I don't.
Pads. It should be. Well, we should be clear. We should be clear that this is pads. These are pads that measure electricity, right? So AED/monitor rather than removing the AED.
Sure.
I mean, whatever. Yeah. Okay. Cool. Any further discussion? Any further discussion about this?
I would just say that is a good idea to write AED/monitor, because you could theoretically leave the AED on. You know what I mean? I mean, if you saw, I don't know, if you happen to walk in and you're transitioning from BLS to ALS, that's a good choice.
Agree with Van Vries.
Very good.
Thank you, Dr. Barbara.
Any further discussion? Okay, hearing none, I don't think we have to vote on this typographical change. Is there anyone on the Medical Standards Committee who opposes or abstains from moving this forward to REMAC for a roll call for approval? Okay, Marie, please proceed.
Okie dokies. Okay, Glenn Aceda,
Yes.
Brad Kaufman.
Yes.
Dario Gonzalez,
Yes.
Nathan Reisman,
Yes.
Pamela Lai,
Yes.
Nick Alexandru,
Yes.
Doug Isaacs,
Yes.
Jonathan Berkowitz,
Yes.
Michael Redlener,
Yes.
Joseph Schenker,
Yes.
Arthur Cooper,
Yes.
Mark Cantor,
Yes.
Robert Krupe,
Yes.
Timothy Stiles,
Yes.
Laura Ivacoli,
Yes.
Wallace Carter,
Yes.
Kevin Munjal,
Yes.
Cindy Basilios,
Yes.
Matthew Harris,
Absolutely.
Jessica Van Voorhees, Ben Zabar,
Yes.
Sorry, I got the yes from Jessica. Ben Zabar,
Yes.
Paul Barbara,
Yes.
David Benelli.
Yes.
Unanimous. Yay.
Thank you, Dr. Leidy. Next protocol, please.
Okay, great. The next protocol is the pediatric severe bradycardia protocol. There were not any major changes that were put in here except for clarifications just for the CFR level in terms of the ventilation rate. And then that's going to be needed for certain heart rates as delineated in the protocol. Otherwise, the epinephrine or the atropine dosing has not changed, and it was just for language clarifications.
Any discussion regarding this protocol? Hearing none. Anyone on medical standards opposes or abstains from moving this forward to REMAC? Thank you, Marie. Please do the roll call.
If it will, was it just a language change? I'm sorry. Was it
Yeah, Joe, it was just mostly like a lot of like just some clarification for the language from the current protocols, but otherwise there was not any changes in dosing or medications.
an intent of the protocols?
I think we might have. I think the atropine dose might have changed a little bit.
Oh, there's too many people. Oh, there's too many people.
We made some clarifications to the rate just to be more consistent with the PALS language. I think that was different from the prior protocol. And I think Ben was mentioning, I think we also just made sure that the current atropine dosing reflects the 2020 PALS ASHA guidelines. Nothing groundbreaking.
Okay. Okay,
And
but that's
Joe,
reasonable
also as
enough.
well,
Let's just vote on this. Go ahead, Pam.
Oh, I was just going to say that this was sort of moved out of the shock protocol for pediatrics. That since we do have adult dysrhythmia protocols, this was then sort of taken out as a pediatric sister version and is separated out into its own protocol. So that's why we have these.
Thank you. Any further discussion? Okay, anyone on the Medical Standards Committee opposes or abstains from moving this forward to REMAC for vote? Okay,
Hey,
Marie,
David.
let's proceed with, yes.
David, I just have a question on under EMT, under paramedic, actually, number 8. If severe bradycardia is caused by an increase in vagal tone or primary AB block. I don't know that anybody would know that right from the beginning, but I think you're defining severe bradycardia up on top. I don't think you necessarily have to put that language in there after that follows, but that's just my guess.
Dr. Harris?
Yeah, I'm not sure that dramatically changes the protocol. Whatever, that's fine.
So yes, Ben.
It might take me a second to find, but I think we got that language from PALS. And I think the reason why that was important, because they don't want them just sort of routinely giving atropine, but it's like you specifically, post intubation and the guy, they Brady down. That's when they want you to give, or someone was eating, that's when they want you to give the atropine. They don't want you to give it routinely. So there was a reason for that.
And I just pulled it up. I can share it with the screen for that.
But Matt, you're saying it is in the PALS?
Correct. I'll share it.
Wait, speak up. Oh, you said yes?
Yes,
Right.
Loud Kids. Yeah.
Yeah, so that language is from PALS. Matt has it.
Okay, very good. So do we need to just put this on the screen, or is everybody comfortable with leaving the language from PALS? Okay, does anyone wish to have Matt put this up? Or are they comfortable with leaving this language from PALS? Okay, hearing no objections, let's move on with the vote. Is there anyone on the Medical Standards Committee who opposes or abstains from moving this forward to REMAC? Thank you very much, Marie. Let's do a roll call, please.
Lenaceda,
Yes.
Brad Kaufman,
Yes.
Dario Gonzalez,
Yes.
Nathan Reisman,
Yes.
Pamela Lai,
Yes.
Nick Alexandru,
Yes.
Doug Isaacs,
Yes.
Jonathan Berkowitz,
Yes.
Michael Redlener,
Yes.
Joseph Schenker. Joseph Schenker,
Yes.
Arthur Cooper,
Yes.
Mark Cantor,
Yes.
Robert Crupi,
Yes.
Timothy Stiles,
Yes.
Laura Ivacoli,
Yes.
Wallace Carter,
Yes.
Kevin Munjal,
Yes.
Cindy Basilios,
Yes.
Matthew Harris, Jessica Van Voorhees,
Yes.
Benjamin Zabar,
Yes.
Paul Barbara,
Yes.
David Benelli.
Yes.
And I like the old Staten Island Hospital behind you, Paul.
It looks a little different now.
Oh, it looks very different now.
I was born there.
I was a candy striper there.
Okay, let's move on. Dr. Light, the next protocol, please.
Oh my God.
Sure. So the next protocol we have are the acute coronary syndrome suspected myocardial infarction chest pain protocol for adults. For here, there is just the same language that we've had for the CFR level in terms of administering the 324 milligrams of aspirin if trained to do so. For the EMT, that has not changed in terms of, if available, to assist the patient with their prescribed nitroglycerin for blood pressures greater than 120 millimeters of mercury. For the paramedic section, there is a slight change on here after discussion in the protocol committee. to make this systolic blood pressure limit be similar to the EMT level, so that paramedics are to only administer the nitroglycerin only if the systolic blood pressure is greater than 120.
Thank you. Any discussion on this protocol? It's pretty straightforward. Okay, hearing none. Anyone on the Medical Standards Committee opposes or abstains from moving this forward to REMAC for approval? Thank you. Marie, let's have a roll call, please.
Okay. Glenn Esteda,
Yes.
Bradley Kaufman,
Yes.
Dario Gonzalez,
Yes.
Nathan Reisman,
Yes.
Pamela Lai,
Yes.
Nick Alexandru,
Yes.
Doug Isaacs,
Yes.
Jonathan Berkowitz,
Yes.
Michael Redlener,
Yes.
Joseph Schenker,
Yeah.
Arthur Cooper,
Yes.
Mark Cantor,
Yes.
Robert Croupi,
Yes.
Timothy Stiles,
Yes.
Laura Ivacoli,
Yes.
Wallace Carter,
Yes.
Kevin Munjal,
Yes.
Cindy Basilios,
Yes.
Matthew Harris,
Yep.
Jessica Van Voorhees,
Yes.
Ben Zabar,
Yes.
Paul Barbara,
Yes.
David Benelli.
Yes.
Okay, unanimous, approved.
Thank you, Dr. Lai. The next protocol, please.
All right, great. So the next protocol is sort of the general approach to the adult patient with dysrhythmia, with the subsequent references to the specific dysrhythmia subprotocols. So this one, just in terms of general management, especially in terms of like for the paramedic patient, for the paramedic level, it's still the same, that they are to begin cardiac monitoring, treat the specific dysrhythmias according to the following subprotocols, and then afterwards perform, record, and evaluate the 12-lead EKG, obtaining intravascular access, and then continuing to monitor for the vital signs every 2 to 3 minutes.
Thank you. Any discussion? Both medical standards and REMAC members. Okay, hearing none. Anyone on the Medical Standards Committee objects or abstains from moving this forward to REMAC for approval? Thank you. Marie, let's do a roll call, please.
Mhm. Okay. Okay, Glenn Esteda,
Yes.
Bradley Kaufman,
Yes.
Dario Gonzalez,
Yes.
Nathan Reisman,
Yes.
Pamela Lai,
Yes.
Nicholas Alexandru,
Yes.
Doug Isaacs,
Yes.
Jonathan Berkowitz.
Yes.
Okay, Michael Redlener,
Yep.
Joseph Schenker, Arthur Cooper.
Yes.
Okay. Mark Cantor,
Yes.
Robert Croupi,
Yes.
Timothy Stiles,
Yes.
Laura Ivacoli,
Yes.
Wallace Carter,
Yes.
Kevin Munjal,
Yes.
Cindy Basilios,
Yes.
Matthew Harris,
Yes.
Jessica Van Voorhees,
Yes.
Ben Zabar,
Yes.
Paul Barbara,
Yes.
David Benelli.
Yes.
We're almost done, folks. This is good. Unanimous.
Pam is shaking her head over there.
No? Well, we
I'm
got
sorry.
20.
I'm sorry, Marie. We're not almost done, but we are still going through it. We are going strong. So for the next protocol, so this is the start of one of the sub protocols for the dysrhythmia for the sub protocols for the dysrhythmia section. So that you'll see these are only for paramedics. So you'll see that the change from the current protocols is that there is a distinction between for each of these for treatments and medications that paramedics are to perform for unstable dysrhythmia versus the stable dysrhythmia. So for example, for the AFib flutter protocol, you'll see that for the unstable patients, they're to perform the initial synchronized cardioversion. And then for the stable patients, they are to consider contacting online medical control for medication administration options. And then you'll see the medical control options that are here, both for the persistent unstable patient as well as for the stable patient that they can request through online medical control.
Okay, since there are 4 sub-protocols, maybe we can just vote on all of the 4 sub-protocols at once. Maybe we can review them once at a time and then vote on all of them.
We can do that.
Okay, good. Any discussion on this sub-protocol from REMAC or from medical standards?
Hi, this is Brad. In the medical control options 3, the second bullet, should that say consider synchronized cardioversion as opposed to continue?
I think so. Or
I'm not sure what continue.
Just repeat.
I don't think our medical.
I think it's consider. I think it's a continuous repeat.
I think.
Yeah, I think it was meant as a repeat as needed.
Yeah.
Yeah, it's an unstable protocol. I'm not sure why
Yeah.
even it falls under that then. It's just considered the repeating.
Yeah.
Which the paramedics should be doing anyways, understanding since it's unstable.
True. Okay, you want to just write repeat, and that's it.
Will do.
Or consider repeating.
Also, maximum joule setting. I don't think we mean like the maximum the machine can do. The maximum that worked previously.
So I think that the issue is that I don't think that it worked previously. So it'll be that for whatever the maximum joule setting for the monitor is going to be, because there's still going to be unstable dysrhythmia.
Thanks.
That is correct. So it should be the maximum. Just delete the continue over there, Pam.
That's what I'm doing on the paper version. So
just formatting is for number 3. Should it also have option A, option B?
Sure.
Medical control options.
Sure.
David?
Yes.
Yeah. Consider repeating. I'm not sure that actually works. The implication there is you repeat it once. Whereas I think the sense of this medical control option is that you repeat synchronized cardioversion, until basically it stops, right? So I'm not sure what
I agree with you,
wording is. I'm not sure what the best wording is, but I don't think consider repeating is it.
I agree. I think we should just say repeat because there's an option. It's an option already. So there's option is for consideration. I agree with you. Okay. Any further discussion on this sub-protocol? Thank you. Okay, let's move on to the next sub-protocol, please.
Sure. So the next protocol is for the Brady dysrhythmia for the adult patient. So again, for the unstable Brady dysrhythmia patient, that is with the definition for the ventricular rate less than 50 beats per minute and signs of decompensated shock. And then it's the administering the atropine, and then to begin continuous pacing. And then for the stable Brady dysrhythmia, they are to consider contacting online medical control for medication administration options. And again, these, I think the one that was added on here is the epinephrine drip that was proposed at the protocol committee meeting. This was further research as well as being recommended by AHA. I believe it was in the, I think the state protocol actually has a norepinephrine on there, but norepinephrine actually can be a cause of bradycardia. So this was to be in line with the AHA guidelines for the epinephrine.
Thank you, Dr. Lai. Any discussion on this sub-protocol? I agree, Brad. Matt won't. Let's move on. Next protocol.
Okay, the next protocol is the supraventricular tachycardia for the adult patient. So again, we have for the unstable SVT as well as for the stable SVT. Under the stable arm, they are able to administer the adenosine as well as repeat dosing as needed if there's no evidence for the cardioversion. And then again, here just for the medical control options on there, they have the option to be administering the diltiazem as well as amiodarone.
So this has not changed much. Any discussion regarding this protocol, sub-protocol? Thank you. Let's move on to the last sub-protocol, I believe, right?
You are correct, David Minelli. So the last sub-protocol is the ventricular tachycardia with a pulse or any wide complex tachycardia, undifferentiated or unknown type. So again, we have for the unstable VTAC, we have patients that are going to be undergoing the synchronized cardioversion. And then for the stable ventricular tachycardia, again, it is inserted here in addition to the amiodarone, that lidocaine is here, as well as for being an option. And then another as again, for persistent stable VTAC with a pulse after the administration of one of the above antidysrhythmic medications, paramedics may consider to administer the other antidysrhythmic medication if available. So that would be in the cases of if they initially administered amiodarone, patient is still in VTAC, then they could administer lidocaine without contacting medical control. Otherwise, the medical control options for the mag sulfate, calcium chloride, and the sodium bicarbonate have all remained unchanged.
Any discussion regarding this protocol?
David, it's Jason. I have 2 quick points on this, only because it actually came up on a case yesterday. Do we really want to change antidysrhythmics after one attempt, or is it to consider a repeat dose of an amiodarone or a lidocaine before switching? I actually don't have a preference either or. It's been relatively safe in practice to switch. But some of the members wanted to say they spoke to medical control and they considered repeated a drip of amiodarone. Yes, because lidocaine really wasn't available for them. That's besides the point.
Well, yeah. I mean,
this was discussed at protocol committee. I think that, it was believed that, just with the general discussions at the meeting that they would want to have the providers be able to switch if they did have those medications available to them.
Okay, switch on their own without speaking to medical control.
Yes.
I think that's fine, Jason. I think it's fine.
I'm not so opposed. It's not like you're mixing.
But I think Jason's point is that they can't, if they don't have the other one available, they're not allowed to repeat the first one if the other one's not available.
Right, and it's not an.
If the other one's available, they're allowed to switch, but they have to call medical control to repeat if it's not available.
It says administer the other. It doesn't give you an option of repeating the first one, which might have been the intention.
That was probably the intent of the protocol.
That was the intention, yeah.
Okay, yeah. Okay, the second one is, I think over here, the lidocaine is weight-based with a maximum of 100. When we added lidocaine into the prior one, did we add a weight-based, or I think I recall just saying the lidocaine 100 dose?
No, it was lidocaine 100, but the weight-based, according to the HA, is 1 per kg. So we kind of, when we kind of made this, aligned this with the PEDS dosing as well. So it's 1 per kg with a maximum of 100.
I know, but when we added lidocaine earlier on in the night, I don't think it was a weight-based lidocaine.
So before
No,
it was under the cardiac arrest protocol, so then it was just given as just a straight dose for cardiac arrest patients.
Yeah.
Just noted that.
Pesach.
Yeah, I'm just seeing that in this protocol, we're allowing the crew, to Jason's point, to switch antidysrhythmics on standing orders, but in the cardiac arrest protocol, even with medical control, they are not allowed to switch. They're only allowed to give the second dose of the same medication they gave the first time, whichever one that was. So now I'm wondering if, I thought that was the intention there, and then I see this here, and I'm wondering, was that intentional in cardiac arrest, that whatever you start with is what you use the entire time and there's no option to switch?
So I believe that was the intention, because then at that point, if they're going to be if they're going to be contacting medical control for further options at that point, and then they would be asking for the other antiarrhythmic medication.
So in the cardiac arrest protocol, under medical control, when contacting the doctor, it says for administration of the previously given antiarrhythmic. So you have no option to ever give the other one than the one that you gave before, not on standing orders or on medical control.
Yeah, we always have discretionary.
Yeah, I understand. I don't know if this was an oversight or if it's intentionally different between these two protocols.
So I believe it just in terms of for the treatment for the VTAC or the pulse, this was intentionally to be different because then it was thought that with these patients that to try the other antidysrhythmic if it did not help under the standing orders. I think that if that's something that the REMAC wants to do in terms of adding it to the cardiac arrest protocol, even as a medical control option, we can do that with similar language.
So
if that's
for the cardiac arrest, is that something we would make a motion now? That would be later. How would we go about that?
Okay, did we already approve the cardiac arrest protocol, Pat?
We
So
did.
cardiac arrest protocols were already approved with the lidocaine. That was one of the first ones that we did.
Okay, so do we need to just update the language in the medical control option that allows for administration of lidocaine?
I think it's just going to be language that's going to be changed that they can administer the other antiarrhythmic medication, so they can have the similar language to here for that as a medical control option.
Right. I think for that one, Pam, though, you would probably do either a repeat of the original or a change on the medical control option. So it'd just be an or probably into cardiac arrest. I don't personally see why I would have to go all the way back. I think you can just make them after you vote on this one. You can probably make a motion. I don't know. You can answer that.
Okay, very good. So Pam, you're going to make a change in this protocol to reflect Jason's concern?
In terms of,
No, Dave, I think in this one, the intent of their committee was not to.
Okay, very good.
The intent was for this one to keep this one the same. It was to make the addition for the cardiac arrest protocol.
Okay, why don't we vote right now on these 4 sub-protocols, and then we'll go back, okay? Make a note to yourself to go back to the cardiac arrest protocol and just see if we can update the language there. Okay, so any further discussion on these 4 sub-protocols? Hearing not, is there anyone on the Medical Standards Committee who opposes moving these protocols forward to REMAC for approval? Opposes or objects? Hearing none, Marie, let's do a roll call for these 4 sub-protocols.
Yes, sir. Let me find it.
Okay, and then Pam, let's go back to the cardiac arrest protocol just to change the language over there and approve that.
I got it ready on deck.
Wait. So I have 4 sub-protocols here, which we're doing all of them,
All
right?
All of them, yep.
Okay. Glenn Asada.
Yes.
Brad Kaufman.
Yes.
Dario Gonzalez.
Yes.
Nathan Reisman.
Yes.
Pamela Lai.
Yes.
Nick Alexandru.
Yes.
Doug Isaacs.
Yes.
Jonathan Berkowitz.
Approve.
Michael Redlener.
I'm in. Yes.
Joseph Schenker. Dr. Schenker.
I muted myself.
You muted it.
That was yahoo!
Okay. Arthur Cooper.
Yes.
Mark Cantor.
Yes.
Robert Krupe.
Yes.
Timothy Stiles.
Yes.
Laura Ivacoli.
Yes.
Wallace Carter.
Yes.
Kevin Munjal.
Yes.
Cindy Basilios.
Yes.
Matthew Harris. Jessica Van
Yep.
Voorhees.
Yep. I'm sorry. Yes. Marie. Yep.
Okay. Jessica?
Yes, for me too. Yes.
Okay. Ben Zabar?
Yes.
Thank you. Paul Barbara?
Approved.
And David Benelli?
Yes.
Unanimous. Okay.
Thank you. So Pam, let's go back to the cardiac arrest protocol, please.
Right, so here you see the cardiac arrest protocol. So here is under the standing orders, it's the option of the amiodarone or the lidocaine. And then this is the language in question in terms of for the medical control option that we can, I think we can probably just make this either simple and just get rid of this previously given antiarrhythmic medication and just give paramedics the option of administering amiodarone or lidocaine to make it simple.
Yeah, I would think just administer antiarrhythmic, option A, option B.
Yeah, exactly.
Do I need to make a motion for that?
Yes, why don't you make a motion? Because if you do, I'll second it.
So motion in step 21, medical control options to say administer antiarrhythmic medication. Take out the words understanding orders and then make option A amiodarone and option B lidocaine.
I second Pesach's motion.
David, any discussion on the motion?
Dr. Benelli?
Did we lose David?
David, are you on mute?
Not see him in the waiting room.
Oh, my goodness. Okay, well, Dr. Schenker, you are on.
Oh, Vice Chair.
Oh, sorry. Vice Chair, you're on. Sorry.
I'll have it. It's fine. Actually,
Any discussion on the motion?
Yes. Why wouldn't, Dr. Cooper, why wouldn't we just say, for persistent or recurring ventricular fibrillation or pulse and speed tach, and then option A, administer amiodarone, option B, administer lidocaine. That's sort of the same that we do up above.
Yes, Art, that's what the proposition is. I just did not change it on the screen, but that is what has been proposed.
Just to clarify.
No, I know that, but we were saying administer antiarrhythmic medication. But I'm not sure that's
I think just to clarify, we're making Dr. Benelli be back the host because he's back.
Yeah, I'm back. I'm sorry. My Wi-Fi died, but it's back up. So is there where did we drop? Did Pesach make the motion?
Yes.
Okay, and I seconded
and then Jessica seconded it.
Oh, Jessica seconded it. Okay. Is there any discussion regarding this? Okay, quite honestly, I don't even mind making the lidocaine as a weight-based dose up there, but it's fine as it is. Okay, hearing that there's no discussion, is there anyone on the Medical Standards Committee who opposes or objects or abstains moving this forward to REMAC for a revote?
Not a revote. It's a vote from scratch.
Yeah, I have this as its own standing vote.
Good. Okay, no discussion. So let's move it for a roll call on this change. I think it makes sense to keep consistency.
Okay. Glenn Asada?
Yes.
Bradley Kaufman? Dario Gonzalez?
Yes.
Nathan Reisman?
Yes.
Pamela Lai?
Yes.
Nick Alexandru?
Yes.
Doug Isaacs?
Yes.
Jonathan Berkowitz?
Yes.
Michael Redlener?
Yep.
Joseph Schenker?
Yes, please.
Arthur Cooper?
Yes.
Mark Cantor?
Yes.
Robert Krupe?
Yes.
Timothy Stiles?
Yes.
Laura Ivacoli?
Yes.
Wallace Carter?
Yes.
Kevin Munjal?
Yes.
Cindy Basilios?
Yes.
Matthew Harris?
Yes.
Jessica Van Voorhees?
Yes.
Benjamin Zabar,
Yes.
Paul Barbara,
Yes.
David Benelli.
Yes,
It's unanimous. Thank you.
thank you. So let's move on to the next protocol, Pam.
Sure. So I just wanted to bring to the committee's attention. So we still have 1, 2, 3, 4, 5. So 6 protocol groupings left. We still have a lot of multiple protocols within those groupings. Do we still want to move forward?
Pam, well, my question for you, Pam, is how much do you have left to cover for the May 4th meeting?
Excuse me?
We have a second meeting on May 4th. How much is left after this for May 4th or May 3rd, whatever day it was?
Probably about similar amount to the ones that we just went through today.
Plus GOP. Yeah.
Right.
Plus GOP.
Plus the
doesn't go
GOP
to
section.
Albany.
Right.
Let's go through a few more then, and we'll go from there.
I think people can just bail. Let's just keep going. And if we get to a point where we have less than
That
quorum,
doesn't work because then we won't have a quorum and then we're doing this for naught. So if people.
no, I'm saying as long as we have a quorum.
Okay, but we're literally passing these votes by 2 votes. So if 2 people leave, nothing will pass. So we can't say that. If people feel that this is going on too long, we can regroup at another time. I think we should get through 2 or 3 more and see where we stand. So we're
Okay, let's proceed, please.
Yeah.
Okay, great. So we have pediatric dysrhythmia protocols. So again, this has been reviewed by the protocol committee as well as with Matt Harris and Ben to kind of make the language that's going to be similar to PALS for this. This is especially in regards to the cardioversion dual settings that we have under the medical control options that we have for these patients, and then in addition to the adenosine as well. But otherwise, in terms of the, I think the language was just otherwise like mostly just cleaned up from the current protocols.
Yes, Pesach. Pesach, you have your hand raised?
Yeah, with the mute. Sorry. Comment.
Pesach, we can't hear you. Pesach, we cannot hear you.
Can you hear me now? Hello?
I believe he's saying it's for the similar, so Pesach
exactly,
can chime
same
in
comment.
the same comment about the AED pads here under the medical control
Okay.
options that will.
Excellent. Let's just correct that to AED/monitor. Not a problem. Okay, any further discussion?
We're doing dysrhythmia peds. Okay.
Yeah. Hearing none, is there anyone on medical standards who objects or abstains from moving this forward to REMAC? Okay, hearing none, Marie, please do a roll call.
Okay. Glenn Seda. Glenn Seda.
Yes.
Bradley Kaufman.
Yes.
Dario Gonzalez.
Yes.
Nathan Reisman.
Yes.
Pam Lai.
Yes.
Nick Alexandru.
Yes.
Doug Isaacs.
Yes.
Jonathan Berkowitz.
Yes.
Michael Redland.
Yes.
Joseph Schenker.
Yes.
Arthur Cooper.
Yes.
Mark Cantor.
Yes.
Robert Croup.
Yes.
Timothy Stiles.
Yes.
Laura Ivacoli.
Yes.
Wallace Carter.
Yes.
Kevin Munjal.
Yes.
Cindy Basilios.
Yes.
Matthew Harris.
Yes.
Jessica Van Voorhees.
Yes.
Ben Zabar.
Yes.
Paul Barbara.
Yes.
David Benelli.
Yes.
Unanimous.
Okay, thank you. Let's move on to the next protocol. And Pam, if there are protocols that have sub-protocols, let's just do all of them together, please.
Okay, so I will actually just first move on to a standalone protocol that this is going to be a new protocol. So again, this is a protocol for procedural sedation, both for adult and pediatric patients. So you can see that there are a lot of criteria that must be followed in order for this protocol to be performed under standing orders. So again, this protocol, this was moved from the GOP section into an actual protocol because it was felt that there was actually a lot of medicine as well as dosing that did not necessarily belong in the GOP section. So it was moved into a separate protocol that we have here. So you can see that this protocol is going to be for patients who are conscious and who require medications for short-term analgesic or anxiolytic therapy for procedures, just as ones that we had described before in other protocols for respiratory distress, respiratory failure, for CPAP, as well as synchronized cardioversion or transcutaneous pacing. This protocol also does encompass endotracheal intubation to be performed under standing orders with certain criteria that must be met. These criteria that the patient must meet all of the following criteria: that they be adults, they have an altered mental status, respiratory rate is going to be less than 10, SpO2 is going to be less than 90% without supplemental oxygen, as well as there would be no immediately identifiable reversible causes of the symptoms. So for example, like a patient with an opioid overdose that could be, that would be able to respond to naloxone. So the patient would fit all of those criteria in order to be under this protocol for standing orders. These patients must then be monitored using waveform capnography, that has not changed for it. So as you see under the paramedic level, it is going to be that for patients requiring procedural sedation, that they can administer one of the options for the etomidate, ketamine, as well as the benzodiazepines with maximum dosing on there, as well as, again, as reiterated as before, the endotracheal intubation medications that are listed, as well as the post-intubation sedation medications. They are to be administered as well. It was thought that when crafting these criteria for the standing order endotracheal intubation patients, that these would essentially be for the physicians that are on REMAC, that these would be patients that, after speaking to several physicians, that this would be sort of like the patient that, you would not necessarily deny in terms of if they were presented to you during REMAC. And that's why that they do have very specific criteria that must be followed for standing orders. The protocol committee had a very lengthy discussion about this, as this is something that's, I think, that has been always been proposed and has been debated for quite some time. And this is a sort of like a small step towards that direction of having adult patients be treated under standing orders with the certain criteria. Again, this is going to be something that, through REMAC, through the QA committee, that would most likely need to have a stringent QA for this to make sure that this is something that we are not going to be harming patients with, but that was outside the scope of the protocol committee when we met. In terms of the medical control options, they are going to be the similar dosing for adult patients who did not meet the criteria under standing orders, that they would then contact medical control as they currently do to receive the orders that they are requesting. And also, it was also thought that for pediatric patients that the protocol committee did not want to necessarily have that as understanding orders for patients. So it was left as, again, still being a medical control option that they are to speak with medical control before performing any of the procedures. It is also noted on here that all of the options are going to be using intravascular access, because at this point, if there is going to be a patient that is going to be requiring one of these medications, that patient needs to then have intravascular access in order to have for appropriate monitoring, as well as appropriate treatments as needed for any potential adverse reactions.
Thank you, Dr. Lai. Any discussion regarding this protocol? Okay, hearing none. Anyone on medical standards
I have a question,
objects?
Manelli.
Yes, oh, go ahead.
The second bullet under criteria, the second big bullet, in order to perform endotracheal intubation under standing orders, the patient has to meet all of the following criteria, or was the intent of that statement that in order to sedate under standing orders to perform endotracheal intubation?
Yes, in order to sedate, I'm sorry. So that would be language that would need to, that was the intent, but I think that you caught in terms of language.
Thank you. So is there any wording that we need to change here?
I'll just have to end up adding some language on that. That's in order to use sedative medications to intubate under standing orders. They are to meet all of the following criteria, something like that. I'm going to put a note for myself.
Very good. Dr. Kosturko.
You should add something saying that if the patient's hypotensive and pick up, systolic less than 100 to avoid using benzos.
It's very hard to understand you on the train, Lauren.
So I think Lauren is trying to point out, so correct me if I'm wrong, Lauren, but for the hypotensive patient and the peri-intubation patient, there is a key point on here at the end that for peri-intubation hypotension may lead to patient decompensation and or cardiac arrest, that they are to improve the blood pressure via crystalloid fluid and or vasopressors prior to performing the actual procedure.
What about the blood pressure? Can you hear me? Sorry, I'll write it in the comments, but I think we should avoid benzos in hypotensive patients.
Okay. Dr. Kosturko's comment is to avoid benzos in hypotensive patients.
Art has his hand up as well.
I'm sorry?
Art Cooper has his hand up.
Sorry, I did not see that. I apologize.
Okay, thank you. My personal experience is that the ketamine is not a particularly good drug for intubation.
So I think that there's, even for like my personal use, I have used ketamine quite a bit for intubation. It has also been shown in the literature to be a more than adequate induction agent for intubation.
In kids? I'm speaking of kids. I'm not speaking of adults.
So I guess in terms of like for your concern for pediatric patients, they will be contacting online medical control. So they'll be speaking to a physician in order to be obtaining those orders. So they'll have that direct guidance from the physician in terms of medication selection.
Thank you.
I'm not going to follow my sword over this one, but I don't think ketamine for intubation is a good drug for kids. I'll just leave it at that. Thanks.
Okay. Again, the standing for adults, not for pediatrics, and for pediatrics, they will contact non-medical control for approval. Any further discussion regarding this protocol? Hearing none.
Scroll up. Can you scroll up for one more second? Sorry. Okay.
Okay. Hearing that there's no further discussion, anyone on medical standards opposes or abstains from moving this forward to REMAC for voting?
I abstain, Jason.
Well, okay. Anyone else?
This is Kevin Manjal. I don't know enough of the background of the discussion around moving this to standing orders, so I'm gonna, I oppose.
Yeah, that was my point also. Sorry.
Okay.
Why don't we take a vote?
Yes. Well, we just okay. So if there's right now I know that there are 2 abstained and 1 opposed. There has been an extensive discussion about this in the protocol committee, and I urge people who feel strongly about these things to attend the protocol committee meetings. Okay.
Any of them that are every Friday.
Okay. Any further, anyone else opposes or abstain? Okay, hearing not, this protocol passes and goes to medical standard, and goes to REMAC for voting.
Okay. Roll call
Okay.
vote.
Yes, please.
Glenn Aceda,
Yes.
Bradley Kaufman.
Abstain.
Okay. Dario Gonzalez,
Yes.
Nathan Reisman,
Yes.
Pamela Lai,
Yes.
Nick Alexandru,
Abstain.
Doug Isaacs,
Yes.
Jonathan Berkowitz,
Yes.
Michael Redlener,
Yes.
Joseph Schenker,
Yes.
Arthur Cooper,
Abstain.
Okay, Mark Cantor,
Yes.
Robert Krupe,
Yes.
Timothy Stiles,
Yes.
Laura Ivacoli,
Yes.
Wallace Carter,
Yes.
Evan Winjal.
No.
Okay. Cindy Basilios,
Yes.
Matthew Harris.
Yes.
Jessica Van Voorhees,
Yes.
Benjamin Zabar,
Yes.
Paul Barbara,
Yes.
David Benelli.
Yes.
Okay, 1, 2, 3, 4, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19. 19 in favor, carries.
Just for 1 second.
Okay, thank you very much.
Before we move forward, just a clarification to everybody here. If you're not a member of Medical Standards or REMAC, you may not make a motion. You can participate in the discussion, but please do not make motions. They are not valid. So just going forward, everybody just be aware of that. Thank you.
Okay, so let's move on to the next protocol. Dr. Lang.
Great. So the next protocol I want to like to propose to go over to REMAC is the updated Weapons of Mass Destruction protocol. This has, Doug, you can please jump in as you were the group lead on this protocol, but just in short, this was a majorly updated protocol through a lot of research that was done, including speaking with a lot of subject matter experts across the country, both with military as well as other agencies as well, who also have similar protocols in place. There was also a lot of research into what has been updated in terms of our nerve agent antidote kit cache that was provided by NYSEMS and the fire department. So this has all been very much has been a big underhaul in terms of this protocol. But otherwise, like a lot of the criteria and everything that were set forth from this protocol have otherwise been unchanged. Doug, do you want to say something before I go through the protocol?
No, I appreciate that. Emily said it all. Just you can go through the protocol. Now to answer any questions.
Okay, great. So in terms of this protocol, it is only to be enacted as through a class order issued by the FDNY Office of Medical Affairs. For the CFR and all provider levels, you'll see that there is a updated table in terms of the initial management for these patients. In terms of the signs and symptoms have not necessarily changed in terms of the categorizing for these patients in terms of the red, yellow, green, or severe, moderate, and asymptomatic patients. But in terms of the administration, particularly for the less than 18 kilogram patients, this dosing was changed in terms of the administration of the NAC units, or the nerve agent antidote kit. For those yellow patients, they're only actually to receive atropine 0.5 milligram as a auto injector and not receive a NAC kit. So you'll see that for this dosing that there is these weight-based categories that are going to be used throughout for this, just to be able to better accurately and appropriately treat these patients for this. So in terms of treatments, these patients are to be treated to the tag colors, where the red and yellow patients do not delay treatment for decontamination. And then while the green tag patients, they can be decontaminated and then observed closely. After initial management for continued excessive secretions or respiratory distress, they can receive additional atropine auto-injectors based on their weight for the continued symptoms from 0.5 milligrams up to 2 milligrams. Now, this again is going to be something new, whereas under the paramedic section that we have the administration of benzodiazepines that are available in the WMD cache, both options for diazepam as well as midazolam. There are diazepam auto-injectors, but there are not any equivalent for midazolam, but there are the midazolam vials that are available. So we, unfortunately, just with supply issues, with everything else, there are those two options that are available that our providers might encounter. So then these two options are listed under here for the paramedic section. In addition, for any continued symptoms or any other further medical control options, this is going to be medical control options that are going to be through the FDNY OMA response physician, that they can allow any further dosing or any other discretionary orders.
Okay, thank you. So this is a revamp of the current protocol, and
honestly,
and I'm sorry.
No, nothing. Sorry.
Okay, and it's a change for the better. It clarifies a lot of things. Any discussion regarding this protocol? Okay, hearing that there's no discussion. Anyone on the Medical Standards Committee opposes or object or abstains? Moving this forward for vote at REMAC. Hearing none. Marie, please do a roll call.
Okay, so the new WMD protocol. Glennis Seda.
Yes.
Bradley Kaufman.
Yes.
Dario Gonzalez.
Yes.
Nathan Reisman.
Yes.
Hamla Lai.
Yes.
Nick Alexandru.
Yes.
Doug Isaacs.
Yes.
Jonathan Berkowitz.
Yes.
Michael Redlener.
Yes.
Joseph Schenker.
Yeah.
Arthur Cooper.
Yes.
Mark Cantor.
Yes.
Robert Krupe.
Yes.
Timothy Stiles.
Yes.
Laura Ivicoli.
Yes.
Wally Carter.
Yes.
Kevin Munjal. Kevin, you're slowing us up. Come on. Okay, no Kevin. Cindy Basilios.
Yes.
Matthew Harris.
Yep.
Jessica Van Voorhees.
Yes.
Ben Zabar.
Yes.
Paul Barbara.
Yes.
David Benelli.
Yes.
Okay, unanimous, but we're down to 20 members.
I would like to propose that we take the last three protocols and move them to the May 4th meeting so that we can continue. There's still a REMSCO report and a little bit of new business that we need to complete before we can end this call. So I think that this way, I mean, we got through a significant amount. I think that we have now the balance of it remaining for the May 4th meeting, which is a little bit less than what we did or what we had initially for today, and should be manageable at that meeting. What do people think about that?
Great idea.
Second.
Yes.
In favor.
Listen, that was very smooth, and I really do appreciate everybody's cooperation with the rules of engagement, I guess, to get this done. I would like to hand it over to Aditya for a Remsco report, and then I have one piece of new business before we get off the phone.
Okay, it's late, so I'll make it quick. There were several determination of public need. Ridgewood VAC application was approved. Forest Hills was approved. But Bay Community VAC application for territory expansion was deemed incomplete. Interestingly, both Ridgewood and Forest Hills are competing for the same territory, and it remains to be seen how that's going to be resolved. We increased the fee for the determination of public need to $10,000 instead of the previous $5,000. We're using professional legal individuals to be our hearing officers who actually did a tremendously good job, and the fees came up to $10,000. Of course, it's paid by the agency that wants to expand. Marie reminded everyone that Narcan is available for distribution upon request of the agency medical director, so it's in the office. Request it, you'll get it. The next REMSCO meeting will be held April 27th, 2021. See you there.
Thank you very much. Any questions for Dr. Langzam? All right, hearing no questions. The only piece of new business I have is we are coming up to the time of, now that we've passed our bylaws, of voting on new REMAC officers. There have been no submissions. So the current slate is the current slate of officers, which would continue going forward. That will be voted on at our next meeting, which will be May 4th. If anybody would like to put in for a position, please submit your name to Marie and we can add that to the ballot. Any questions? Comments, concerns? Hearing none, I will entertain a motion to adjourn.
So moved.
All right, thank you, everybody. I appreciate the time that everybody put in tonight. That was very, very helpful. Have a great night, everyone.
Thank you. Have a good night.
Thank you. Good night, everyone.
Thanks, everyone.
Better children.